Okay, we're going to talk now about the principles of benefits and non-maleficence. So, um, within legal issues, benefits is the performance of good acts. So, good encompasses proper behavior within the laws or custom, relationships, or the contract. Non-maleficence is the avoidance of evil. So you'll need to know the difference between those two. So the Hippocratic Oath begins with the first is to do no harm. So within the doctors, when they become physicians, they take part of the Hippocratic Oath, and you do too by entering into the medical field. And the first thing is first do no harm. So you act on the behalf of the patient. Proportionality, so the action should not infringe against the good of the individual. Proportionate good must exist to justify the risk of an evil consequence. So there are times where we have to do something that is not good in order to have a good outcome. The avoidance of evil is impossible, so proportionately must exist between good and evil effects. An alternative with less evil consequences is available. You should always ask that. What can we do that would not be as bad as what we're doing? So what are the levels of good intent and evil risk? So you have to weigh out pros and cons of each. What is the probability of the good or evil intent being achieved? And what action or influence do the healthcare team and patients have? So when you look at this, you need to know that every time, if we're going to be doing an air contrast barium enema, that is an evil procedure. But if it's a procedure where we can go in and we can actually see that this child has intussusception and we can fix it, or if this person does have a bleeding ulcer, that we need, or a perforated bowel, that we need to know that. So you have to weigh the good with the bad. So that's the evil versus the benefits. So points to consider. You need to look at the patient's medical problem. You need to look at the acuity of the problem. Is this something that needs to happen right now, or can it wait a week? The goals of the treatment or the procedure. So what is the goal? What's the outcome of this? Is this going to be good or bad? The probabilities of a successful imaging exam. So if you're looking at a person who is curled up into a ball and is frozen that way from a stroke, are you going to be able to do an air contrast BE? Is this going to be successful? Plans in case of a failure or incompleteness. So if the patient gets prepped for an air contrast barium enema, and you think that, yeah, we can probably have a successful exam looking to see where the blockage is, do you have a plan in case that fails? So what contrast are you going to use if you fail, and to get that patient into CT, or are we going to look at nuclear medicine? What are our alternatives? So what is the patient's medical problem, history, diagnosis, prognosis? So the diagnosis is what we think they have, and the prognosis is what we think the outcome will be. So when we talk about what is the problem, acute, or is it chronic, is it emergent, is it reversible, or how is this going to impact the imaging of the procedure? So we have to look at the acuity of the patient to get them in, or get another person in who is more critical. What are the plans in case of the therapeutic failure or inability to complete the exam? So you need to look at that and say, what are the alternatives? The patient needs to be aware of the alternatives so that they can make an educated decision. So how can the patient benefit by the medical and imaging care? So how do we do it with avoiding harm to the patient? That's the goal. There's a lot of alternatives, and we just have to think outside the box sometimes. So justice is the performance of an appropriate procedure only after informed consent has been granted. So medical indication principle is granted informed consent. The physician should do what is medically indicated such that, from a medical point of view, more good than evil will result. The performance of good and the avoidance of evil often come into conflict when medical indication principles or the proportionality of the consequences is judged by the healthcare provider. The conflict between benefits and non-maleficence on the one hand and informed consent and patient autonomy on the other may be explored further by asking how. If the healthcare professional cannot make quality of life decisions concerning the patient, but must make recommendations concerning good and evil, can decision making lead to patient autonomy? So if you really feel that a patient should have something done or not have something done, you are not allowed to explore that with the patient. So the patient may ask you, what would you do? At that point, you can refer to the physician, that's a really tough decision. I'm not supposed to sway you either way. You're supposed to make an informed decision. We can explore all the options for you so that you can make a well-educated decision. So it's really important that you try to keep your personal out of it so that the patient, it's 100% the patient making the decision. If you say, you know what, I really think you should do it, and then something bad happens, that could be labeled as coercion. So you have to be very careful. So when we talk about contractual agreements, we provide that for patient autonomy. So if a patient is considered incompetent, there's a surrogate that's usually assigned to the patient. So the surrogate has obligations. They are to choose what the patient would have chosen if they were competent, while considering the interests and relevance of others. So they hopefully know the patient and know what the patient would have wanted. A lot of the times when we get to patients in skilled nursing, there is no more family, and there's a surrogate that's been assigned to the patient that doesn't know the patient. And this is where it gets really tough. I feel really bad for those surrogates because they have to decide life decisions for these patients that are incapable of doing that. All right. So patients requiring imaging services and enter into a contractual agreement when they agree to enter a hospital and undergo a series of diagnostic studies. Imaging professionals may be in a position to help determine whether a patient is competent to give consent. There are times where you have a Down syndrome patient or a stroke patient or someone that's altered, and you can't get that consent. So if the imaging professional does not believe the patient to be competent, this should be shared with the physician, and at the physician's discretion, a surrogate consent should be sought. So the role of the patient and the professional. So the imaging professional's role is to be aware of the obligations to do good and avoid harm. The patient's role to participate by protecting his or her own good and avoidance of his or her own harm by gathering information about the imaging procedure. So they are supposed to participate in their care and actually give their own questions and what they're concerned about. So the imaging professional, so every imaging procedure has the potential to harm every patient. Invasive procedures, especially radiation, we can cause burns, we can cause DNA changes, the equipment malfunction. I've heard about a tube lock not holding and falling on a patient. I had a tube crack and leak onto a patient with hot burning oil. These all pose danger to the patient, and we need to make sure we have the patient's consent on board. So the patient role, if the patient is in doubt, a second opinion should be sought. So, and that can be under surrogate also, their obligations. They should seek a second opinion if they're not comfortable. So legal issues. The law provides parameters for the delivery of imaging services. The most basic legal parameter is the standard of care. So the standard of care is the obligation of the healthcare professional to do no harm and a duty to provide reasonable patient care. Violation of the standard of care may result in liability imposed on both healthcare professionals and the medical facility in which you're at. So really important that you follow the standard of care. The practice standards, so the educational requirements, the curricula developed for the medical imaging science, all help to establish the standard of care to which the imaging professionals are held to. So you don't want to deviate from that. You need to stay on course. The practice standards may be used to define what a radiologic technologist do and how they do it. Practice standards also may be used to hold the radiologic technologist to a certain standard of care, and we do. So, standards for accreditation for educational programs in radiologic technology is defined by the Joint Review Committee on Education in Radiologic Technology. It's JRCERT, or the American Registry of Radiologic Technology, ARRT. So those are the two people that enforce our accreditation and hold us accountable to our standard of care. So negligence, we've talked a little bit about this in prior lecture, but we're going to go into it again. It's an unintentional tort resulting from actions not intended to do harm. So negligence requires a duty, a breach of that duty, injury, and causation. So if you picture that slide that shows that negligence and then there's a duty, so we were there to do a certain exam, then that breach of that duty, where it went wrong, there has to be injury to the patient, and then causation. So causation is the payout. So reasonable care, the degree of care a reasonable person similarly situated would use. So whether reasonable care is provided is determined by the standard of care from the procedure being performed. So this is where the expert witness comes in if you are being sued. So the expert witness will come in and say, no, that is not the standard of care. That is not what we do. And that's where you fall into trouble. So negligence occurs in situations in which a duty to use reasonable care is owed to another and an injury results from a failure to use reasonable care. So reasonable care may be determined by the applicable standards of care by statute or previous judicial decisions called precedents. So we talked about how in law, sometimes if there's legal cases and it sets a precedent, so that case, whoever won that case or lost that case, people use that as a platform moving forward. So if a duty is not performed with reasonable care, liability may be imposed, most likely. So medical negligence, fail to follow the appropriate standard of care, also called medical malpractice. Applicable standards of care is generally established through the testimony of a medical expert practicing in the same field as the defendant. So I've been called as a medical expert several times. A plaintiff must provide proof that the defendant breached the standard of care and thus was negligent. So the plaintiff has to provide proof that the defendant breached that duty of care and was negligent and caused injury. So written documentation is extremely important. So it's really important that you document. So when we talk about res ipsa liquor, the thing speaks for itself. So it's a legal concept involved in situations in which a particular injury could not have occurred in the absence of the negligence. So pretty straightforward. If a lawsuit proceeds to trial, the imaging professional may have an opportunity to provide his or her personal recollections of the event. However, written documentation is extremely important. So the legal team, so from the attorneys, judges, juries, may indeed take the position that if the event was not documented, it did not happen. I like how they put may. They do. So if it's not documented, it didn't happen. So if you stated that you checked on the patient every 10 minutes or whatever, if it's not written down, it didn't happen. So you need to make sure that you document that you do whatever you do and everything you do. So when res ipsa liquor is claimed as the basis for the lawsuit, all parties involved in the procedure are defendants. Why? Because obviously at least one of them was negligent. They must therefore try to prove that they were not negligent. So that's everybody. So the case I was just in with the guy with the torn patellar ligament, so we had to prove that he did not cause the tear, that the technologist caused the tear, not him. So it was very interesting to see the dynamics of that. So methods to decrease risk. Documentation. So proper documentation creates a medical record that accurately and completely reflects the patient care and can be used to correlate the facts related by witnesses. Incident reporting allows the hospital to immediately investigate the circumstances in the incident and, if necessary, institute corrective action to prevent similar future occurrences. So an incident report at a hospital, anytime something weird happens, you should fill out an incident report. It's usually online. So if a patient has a skin tear, the patient was acting kind of funny, you fill out this little form. It doesn't take long. It's an internal document. It cannot be subpoenaed in court. So you just send it off to risk management, and it tells them, hey, you know, this patient was acting funny, kept asking me strange questions, you know, I think they're going to sue, kind of thing. Or, hey, we slid a patient over and the patient got a skin tear on their elbow. I just wanted to let you know that, you know, I called the nurse, I notified the family, you know, whatever. We put a Band-Aid on it, and, you know, the nurse is going to take care of it. But they need to know what's going on in case there is a lawsuit. They have written documentation of what you did, and that the hospital, the facility, can provide that in the lawsuit, but it's not subpoenaable, which is nice. All right, so correct film identification liability has been imposed in cases based on the incorrect identification of films. So this actually does go along with CR and DR. If you mark it incorrectly and then you annotate over it, or you don't put markers on and then you annotate it, or you pull up the wrong patient and shoot the wrong patient's name with the incorrect film is linked, there's all kinds of things that can happen that can be a problem. So timely distribution of reports. So a lot of you guys are doing cases, your legal papers, on how the reports didn't get out to the doctor in time, or the doctor just put it in the file and didn't read the report, so that there's a huge lung mass or whatever it is. It's required that we turn around those reports quickly. So radiation protection. The NCRP establishes policies and procedures regarding radiation exposure based on the phrase "as low as reasonably achieved," and safety. JCAHO guidelines exist for safety programs and institutional policies and procedures, generally following these guidelines. So JCO, it's now the Joint Commission, so this is an older PowerPoint. So the Joint Commission regulations require that pertinent patient histories be taken on all procedures performed in the medical imaging sciences. So this kills me. When I ask you guys, what was the patient here for? And you're like, I don't know. It's like, okay, they came in for a chest x-ray, right? Yeah. Well, what did it say on the paperwork? And you look, cough. Well, did you ask the patient how long they've had a cough? No. Why not? So the Joint Commission requires that you actually take a patient history on every patient you take an x-ray on. So when I get in there, or Jill gets in there, and we're on you about it, you actually are supposed to, according to Joint Commission, who accredits hospitals, to get that information. Department policies generally mandate that this information be reported on every patient record, which becomes part of the patient's medical record. So if the patient comes in for cough and you ask them, oh, you have a cough? And yes. How long have you had your cough? Oh, I've had my cough for a month. Oh my goodness. Is it a dry cough? Is it a wet cough? Is it, you know, are you coughing up stuff? Or, oh, you are coughing up stuff. Oh, what color is it? Is it green or red, or, you know, just clear? And if, you know, that's where I'm going with this. It's like you need to probe, and then you need to document that in the PAC system, so the doctor knows. I mean, there's a difference between a dry cough from postnasal drip and a cough where they're coughing up bloody sputum. So you need to be able to tell the difference to the radiologist. All right, so that's it. That's, I think, the last of our legal. Very exciting. I'll have your quiz up soon.